I think our next presenter is Dr. Wei. So Dr. Wei is board certified in both internal medicine and hospice and palliative medicine. He completed his his residency in internal medicine at the University of Buffalo and then completed his fellowship in hospice and palliative medicine at Stanford University. He is now an attending physician at the Brookdale Department of Geriatrics and Palliative Medicine at the Mount Sinai Medical Center, practicing both inpatient palliative medicine as well as outpatient palliative medicine and supportive oncology at the Rettenberg Treatment Center. Thank you so much, Dr. Wei.
Thank you for that introduction. Welcome, everyone. It's my pleasure to talk about the prognostication of chronic disease today. I have no disclosures. Our learning objectives for today are to describe the role of prognostication in medical decision-making, apply available tools and models to prognosticate a few common chronic diseases, and to assess patient and family preferences for receiving prognostic information. So why does prognosis matter to clinicians? Well, it's an important element of clinical decision-making. The risks and benefits of any test, treatment, or intervention should be considered in light of the patient's prognosis. It also allows for informed decision-making. And it is an important part of delivering high-quality, patient-centered care. And so prognosis matters from routine ambulatory colon cancer screening all the way to intensive care, life support, and resuscitation. Prognosticating helps with what to expect in the future with respect to a medical condition or a treatment. And hopefully by the end of this talk, prognosis will matter to you because you will believe that it can help patients and families make informed medical decisions and establish realistic goals of care. Now, why does prognosis matter to patients and families? For many of the reasons listed here. It can shape priorities, prompt discussions regarding risks and benefits. It's even been found to reduce anxiety and spiritual distress. And most importantly, the majority of patients want to know. And most of the time, the reasons that these patients give are more related to financial, emotional, and social reasons than just making a standalone medical decision in a vacuum. So how do we prognosticate? There are two main components. One is the formulation, which involves interpretation of clinical judgment along with evidence-based data to make a prediction. And then there's the communication portion, where we come up with a way to effectively communicate that data to someone. So what can we prognosticate? Quite a bit, actually. We can prognosticate side effects, the likelihood of symptoms, need for interventions, loss of function, hospitalization, recovery, and even treatment response. So here are a few prognosis and treatment recommendations. If the prognosis is less than 7 years, the recommendation is to stop colorectal cancer screening. Less than 5 years, you don't need to do breast cancer screening. 2 to 3 years, you have a more liberal blood pressure target. The big one, obviously, is once the prognosis is less than 6 months, people are eligible for hospice. And for a more niche prognosis, for 4 to 6 weeks, we sometimes use methylphenidate stimulants instead of SSRIs for depression. Now, why do we as clinicians avoid prognosticating? One thing is that we don't want to take away hope. We don't want to, there's guilt associated with not being able to offer curative treatments. Maybe people find it, or we find it time-consuming and difficult. There's been a few studies that show that physicians favor optimism over accuracy. Sometimes we think that the patient and family may not want to know. There's this fear from us, the clinicians, of diminishing hope, causing distress, reducing quality of life. And as we know, the estimates are not exact. If we think these estimates are inaccurate, well, what's the point? Well, the point is, by not communicating prognosis, there's a risk of profound misunderstanding. Take this large study for patients, almost 1,200 patients with metastatic cancer, stage 4 lung or colorectal cancer, and almost 3/4 thought that chemo might cure their cancer, when in fact this is only a palliative treatment for their advanced stage cancer. What else happens when we don't talk about it? We find that there's a much more aggressive care at end of life. There are higher rates of intensive care, including resuscitation and CPR, in patients who do not know their prognosis compared to those who do. We just had a talk on hospice. There's late hospice enrollment, and there's some studies show that families actually do a little bit worse. There's lower satisfaction. Patients or families report being less prepared about what to expect at the time of death. There's lower confidence from families in participating in patient care, and potentially some higher rates of depression in families. Now, do patients want to know prognosis? For the most part, yes. So there's a study here showed that 75% of patients wanted to be told if their doctor thought they had less than 1 year to live in order to prepare financially, put affairs in order, say goodbye. And other studies show, up to 98% of patients want to know. And one other study showed that where about 3/4 of patients wanted to know, but only 18% were told. Now, does telling prognosis take away hope? There's a very small study here looking at 27 patients with advanced cancer. They were given decision aids with information on likely treatment effect, including a 0% chance of cure. This is a treatment designed to only limit the spread of cancer, not cure it. And these patients are rated on level of hopefulness before and after they went over this information. This study used what's the Hearth Hope Index, basically 12 questions. And looking here before the information, after the information was shared, no change in the scoring. So there hasn't been that much data to show that hope can be taken away from patients. I will say on the other hand, there have been a couple studies showing lower patient satisfaction ratings for oncologists when they were told that cancer was not curable. There's no improvement in anxiety and depression in families in the ICU setting with prognosis sharing, and perhaps possibly a worsening of PTSD symptoms with this information sharing. So there are 3 general models of disease course for chronic illness. You have the acute on chronic exacerbations of disease, such as congestive heart failure, COPD, end-stage liver disease. At the bottom, you have dementia, which has a much more gradual and predictable decline. And finally, you have cancer, where patients actually typically maintain a good function for some time until some point when they have a more precipitous drop in their function. Let's start with Miss A for our first chronic illness. Miss A is a 75-year-old woman with heart failure with an ejection fraction of 20% who's admitted to the hospital. At baseline, she becomes short of breath while bathing or dressing. Right now, she has a sodium of 130, a creatinine of 2.1. She becomes hypoxic and moves to the ICU on non-rebreather. Her family asks, will she make it out of the ICU alive? So heart failure affects more than 5 million patients in the US. About 50% of patients die within 5 years of diagnosis. The mortality is often unpredictable. Anywhere from 30 to 50% are considered sudden death, which is defined as not anticipated, death within an hour of onset of new symptoms, or within 24 hours of last being well or at baseline. Fortunately, a lot of medical medications and device therapies improve the prognosis. One of the most common models we use to predict prognosis in patients with heart failure is the New York Heart Association classification. It goes from class 1 all the way to class 4. Class 1 patients have no limitations, basically no symptoms, all the way to class 4, which is defined at being short of breath or having symptoms at rest without any activity. Another model is the Seattle heart failure model, which is used to predict prognosis with and without specific interventions. Predominantly, this model was created to look at left ventricular systolic heart failure, but still can be extrapolated to different types of heart failure. And there was a study in 2012 trying to find ways to predict survival of less than 6 months. And what they found was that in hospitalized CHF patients, either NYHA class 3 or class 4, if they have 3 or more of the following features, and these features can be categorized as either clinical characteristics or kind of lab objective data. So things like age, other medical issues, how many hospitalizations they've had for CHF, um, their dependency in activities of daily living, any history of other cardiac issues, and then over on the right side you have ejection fraction less than 20, BNP, troponin, elevated C-reactive protein, any weight loss, low blood pressure, elevated creatinine or hyponatremia. And so that brings us to our first hospice eligibility criteria, as defined by the Centers for Medicare and Medicaid Services. By definition, patients that qualify for hospice benefit are supposed to have a prognosis of less than 6 months. And the CMS has these criteria for many different chronic diseases. So for CHF, what is required is NYHA class 4 and receiving optimal treatment, considered to be treated with diuretics, vasopressors, and these patients are either not a candidate for any surgical procedures or they decline those procedures. And then there's some supporting factors that can help guide the decision if a patient qualifies for hospice. So I believe you already heard that a lot of patients enroll late in hospice. Even in heart failure patients, that's even more true. Almost a quarter of patients that are discharged with hospice die within 3 days. The average median survival in hospice for these CHF patients is 11 days, compared to the median of 18 days for hospice patients in general. So going back to Ms. A, does she meet the CMS hospice criteria? And can we estimate prognosis as less than 6 months or greater than 6 months? So no, she technically does not meet the hospice criteria because she has NYHA class 3 heart failure instead of class 4, right? She only becomes short of breath while she's bathing or dressing. Even if it's light activity, she does not short of breath at rest. But based on the calculators we have, we can estimate prognosis of less than 6 months. She's over the age of 70. She has an EF of 20%. She is hyponatremic and has an AKI, elevated creatinine. So these tell us that she likely has a prognosis of less than 6 months. Moving on to COPD. COPD is the 5th leading cause of death in the United States in 2024. Over 15 million adults have been diagnosed. And there was a study that showed that over half of patients with COPD were unaware that they had it. Here we have Mr. B. He is a 72-year-old with COPD on home O2. He mostly spends his day in a bed or chair. He was hospitalized last month with a COPD exacerbation. Now he is readmitted to the hospital with altered mental status and an elevated CO2 of 70. He's currently intubated. We're coming up on day 3, and his creatinine is rising. His family asks you what to expect going forward. So for hospitalized COPD patients, the PCO2 is an independent predictor of mortality. If they have a PCO2 of over 50, 10% will die during the admission, a third will die within 6 months, and 43% will die within 1 year. They found that other factors that increase mortality: previous mechanical intubation, previous failed extubation, or intubation greater than 72 hours. We also look at the FEV1, or the forced expiratory volume in 1 second. The normal range is close to 100%. It's a measure of obstruction, so the lower it is, the worse the obstruction is. So if the FEV1 is less than 35% of predicted, about 25% will die within 2 years, and about 55% will die within 4 years. Lastly, we'll talk a little bit about the Bode index. Basically, it's a scale to predict risk of death in COPD patients by combining 4 different independent variables. The first one, B, is BMI. The O is obstruction, so just using FEV1. The D is dyspnea, basically how short of breath they are. This is using a validated scale called the MMRC, or Modified Medical Research Council scale. And then the fourth component, E, is exercise tolerance. So all of these are validated independent factors. Dyspnea alone is an accurate predictor of 5-year survival, and the 6-minute walk test is also an independent predictor of survival. So looking at the 4 quartiles based on the severity of the Bode scale, we can see that the worst quartile, the 4th quartile, the median lifespan would be about, let's say, 39, maybe 40 months, so just over 3 years. So in terms of the COPD hospice eligibility criteria, what's required is that someone must have disabling shortness of breath at rest while on oxygen, which is poorly responsive to bronchodilators or medications, and a decreased functional capacity, basically a significantly low FEV1. Also, what's required is noted progression of lung disease. So this can be more frequent emergency room visits, more frequent admissions, a further decrease in FEV1, or a decrease in functional capacity. And then some of the secondary supporting factors, hypoxemia, hypercapnia, right-sided heart failure, unintentional weight loss, and a resting heart rate of over 100. So going back to Mr. B, does he meet hospice criteria, and can we estimate his prognosis as less than 6 months or greater than 6 months? So he does meet the criteria for hospice. He is hospice eligible, and his prognosis is likely less than 6 months, but we have limited tools for prognosis that short. So he does have significant dyspnea, spending most of his time in bed or chair, more admissions, and then using the study that we found for hospitalized COPD patients, he has a PCO2 of greater than 50. He's been on the ventilator for 72 hours. So that makes us predict that his prognosis is less than 6 months. Moving on to end-stage liver disease, almost 4 million adults have been diagnosed with liver disease. More than 3/4 of adults with hepatitis C are baby boomers. And end-stage liver disease is the 9th leading cause of death in the United States in 2024. And once someone progresses to decompensated liver disease, survival is about 2 years. Here we have Miss C. She is a 68-year-old woman with cirrhosis of unknown etiology. She's had multiple esophageal variceal bleeds in the past. She presents encephalopathic, so she's very confused. She was intubated for airway protection and is currently in the ICU. She has renal failure requiring dialysis. Her INR is elevated at 1.6, and her albumin is low at 2.1. You calculate her MELD score as 31. What is her prognosis? So there are several models for mortality in this patient population. MELD is very common. The other one that is used is the Child-Pugh score or Child-Turco-Pugh. We'll focus primarily on MELD for today. So as you probably know, MELD is used for transplant prioritization and prognostication. The original MELD score included bilirubin, creatinine, and INR, and now we often include serum sodium with that. So looking at a MELD of 31, the MELD looks at 3-month mortality, whereas the Child-Pugh or Child-Turco-Pugh score looks at 1 and 2 year mortality. By looking at a MELD of 31, like our patient here, estimates a 52.6% mortality in 3 months. Here is a graph of the 3-month survival based on MELD score. And then looking at the end-stage liver disease hospice criteria, what's required is significant synthetic impairment, so basically a PT of greater than 5 or INR greater than 1.5, as well as an albumin of less than 2.5. The patient also must have end-stage liver disease with one or more features of refractory decompensated liver disease. So that's either ascites, spontaneous bacterial peritonitis, hepatorenal syndrome, hepatic encephalopathy, or variceal bleeding. And then some of the supporting factors, malnutrition, muscle wasting, ongoing alcohol use, hepatocellular carcinoma, liver cancer, hepatitis B surface antigen positivity, and hep C refractory to interferon treatment. And just for you to know, that 80 grams of ethanol per day works out to be about 6 or 7 drinks per day. Going back to Miss C, does she meet hospice criteria? And is her prognosis less than 6 months? So yes, she does qualify for hospice. She is hospice eligible, and her prognosis is likely less than 6 months. So she has a decompensated liver disease, and she has synthetic impairment. Her INR is over 1.5. Her albumin is less than 2.5. And with a MELD of 31, as you saw previously, about a 50% 3-month mortality. Moving on to dementia, which affects over 5 million Americans. It is a leading cause of morbidity and mortality, and it was the 6th leading cause of death in the US in 2024. For prognostication in dementia, this particular study from 2012 looked at patients with advanced dementia, defined as patients who are dependent in all of their activities of daily living, meaning that they're bedbound, they're incontinent of urine and stool. Generally, these advanced dementia patients have a median survival of about 1 to 2 years. And what they found was that if these patients become hospitalized and have one or more of the following, then their median survival drops down to 6 months. So either they have malnutrition, defined as a BMI of less than 18.5, or decreased oral intake, or significant weight loss. If they have the evidence of a pressure ulcer, if they are over the age of 90 and male, or if they have a nasogastric tube or any other kind of feeding tube. If they have any one of these features, then their prognosis drops down to about 6 months. So another calculator we use very often to predict mortality in dementia patients is found on ePrognosis, specifically the Mitchell Index, which looks at nursing home adults 65 and older, looking at 6-month survival, basically asks 12 questions, including age, sex, do they have shortness of breath, do they have pressure ulcers, do they have limitations or dependency in their activities of daily living, are they bedbound, do they have insufficient PO intake, do they have bowel incontinence, is their BMI less than 18.5, have they experienced recent weight loss, and do they have CHF? So based on the score, obviously the higher the score, the more severe their mortality is. You can see that those who score the highest have a 6-month mortality of anywhere from 34 to 62%. So what's commonly used for dementia patients to classify the severity of the dementia is the FAST, or Functional Assessment Scale test. It describes how advanced the dementia is, originally designed for Alzheimer's dementia, but in practice is used for many similar dementias now. And it's recommended to use this for hospice eligibility. So if you see here, stage 1, basically someone has no difficulties with their dementia, all the way down to stage 6 and 7, which I've highlighted here, where they start to lose their ability their activities of daily living, their ability to dress themselves, bathe themselves, toilet themselves, feed themselves, and then they eventually lose the ability to speak intelligible words and walk. So the dementia hospice eligibility criteria, generally, if you look at CMS, they require FAST 7C. So these patients, again, are unable to ambulate, dress themselves, bathe themselves. They have urinary and fecal incontinence, and they speak fewer than 6 intelligible words. In addition to 7C, they also need to have one of the following medical complications in the last 12 months. Some sort of infection, like an aspiration pneumonia, sepsis, or pyelonephritis, multiple late-stage decubitus ulcers, fever that's recurrent after antibiotics, or significant weight loss in 6 months, or a decreased albumin. I will say that I think some hospice agencies use 7C alone or a FAST 7A plus one of these medical complications. And for our last chronic disease, we'll talk about cancer. Almost 2 million people were estimated to be diagnosed with cancer in the US in 2023. It is a significant direct and indirect medical cost. And it is the second leading cause of death in the US last year. And if you remember back to earlier in the talk, with cancer progression, looks a little bit different than the other diseases we've talked about. Remember that patients with cancer, even as the cancer progresses, their functional status stays relatively the same until at some point there's a tipping point where their functional status decreases extremely rapidly. So clinical factors that affect cancer prognosis, as you might expect, the type and location of cancer, the cancer stage, the cancer grade, the receptor status of the particular cancer, the patient age, their general health, their functional status influences that, and of course, their response to cancer-directed therapy. And just so you know, there are many prognosis calculators that exist for many specific types of cancer, not all, but many. But in general, when we evaluate prognosis in cancer patients, we commonly use these following scales that focus on more general functional status. So one is the ECOG, and then we also use the Karnofsky or palliative performance scales. So the ECOG, as you probably know, is used by oncologists to assess fitness for systemic therapy or cancer-directed therapy. They do this because patients with worse performance statuses typically means higher risk of adverse events, including a risk of death. And it focuses on the ability to do different types of work and on how much time is spent confined to a bed or chair. So ECOG goes from grade 0, where someone's fully active with no limitations, all the way to ECOG 4 and 5, which are incredibly disabled or dead. This is the Karnofsky performance scale, which is a percentage scale where 100% means someone is completely normal with no complaints, basically no evidence of disease, all the way down to completely bedbound, expected, basically when someone is 30% or below, you could use that to describe patients who typically get admitted to the hospital. And then the palliative performance scale is sometimes used interchangeably with the Karnofsky scale. And here it's just broken down a little bit here with the different categories that reflect functional status. Like, are they able to walk? Their activity level, basically, are they able to work or do housework? Their ability to take care of their ADLs, right? Their activities of daily living, their PO intake, and then their level of consciousness. And then here is a representation of how the Karnofsky palliative performance scale correlates with the ECOG, and it actually correlates fairly well. And then there was a study from 2014 that found that the prognosis correlates pretty closely with functional status. So this was an outpatient cancer center palliative care clinic over the course of 3 years, looked at patients, and it found that with the later stage Karnofsky or ECOG, prognosis could be in the range of 25 days, maybe 55 days for the lower functional statuses. For hospice eligibility, the patient either has to have disease with distant metastasis at presentation or diagnosis, or that there has to be progression from an earlier stage of cancer to metastatic cancer with either a continued decline in the patient in spite of therapy, or the patient declines further disease-directed therapy. So for the last part of this talk, I wanted to briefly discuss maybe how to communicate prognosis. This is the communication, the foretelling part. So when talking about prognosis, the most important thing is to ask. Ask for permission. How much do you want to know about the likely course of your illness? And is that something that everyone in the room wants to hear? So there are a couple different ways to talk about prognosis. There's the temporal prediction, right? The how long someone will live. And we generally give these in a range, right? So hours to days, days to weeks, weeks to months, etc. Another common way to talk about prognosis is the best case, worst case, and maybe most likely case scenarios. And then there's the probabilistic prediction of survival, the percent chance of being alive at a certain time, like making it to a specific date. When talking about prognosis, we talk a lot about responding to emotion, and behind that is the theory that your emotional brain reacts faster than the rest of your brain, and so if someone is overcome with emotion, it's really hard to process any additional information, hear anything else, make decisions, unless we kind of address the emotion in the room. So common response to emotion, what I just said, is hard for most people to hear. I wish I had better news to tell you. And then another part that's important about prognosis is kind of like a teach back or checking for understanding after you talk to them. So tell me what you're going to tell your family about this conversation, or tell me what you're taking away from this discussion. There are a lot of great communication resources. There's the Vital Tips, Vital Talk app. It looks a little bit different, but has great categories for any kind of topic you'd be interested in. Lots of literature has been written about communicating with seriously ill patients. And the take-home points is that many, but not all patients and families want to discuss or hear prognosis. Prognostic information is useful for decision-making, both for clinicians and for patients and families. And there are a lot of existing tools to predict prognosis, but some of them have limitations, but they can still be used to guide discussions. So I have two questions listed here just to wrap up. Question one, we have Mr. D, 74-year-old, at a nursing home with dementia. He was recently hospitalized with aspiration pneumonia. He is dependent in all of his ADLs. He can smile, has minimal speech, and is fed via a percutaneous gastrostomy tube. And he is incontinent and bedbound. So at an outpatient clinic visit, his daughter asks you whether he is due for a colonoscopy. Do you recommend colonoscopy for this patient? Of course, the answer is no. Based on his dementia, he's a Fast 7C. He's actually even eligible for hospice at this time if the family and patient are open, or the family is open for it. And the society guidelines say that if the prognosis is in less than 7 years, you do not recommend colon cancer screening with colonoscopy. Question two, Mr. Jones is a 77-year-old man with decompensated cirrhosis due to hepatitis C. He is encephalopathic and is being treated for SBP. His MELD is 33. You are meeting with his 3 adult children to discuss goals of care. His daughter asks you, how long do you think he has left? What is the best response to this question? A, it is hard to say. B, on average 3 months. C, likely weeks to months. Or D, is that information that everyone wants to hear? And the answer is D. Prior to sharing prognosis, you want to make sure that all parties present want to hear it. In general, we try to provide prognosis in a range in these kinds of situations. Acknowledge the patient or family's emotional reaction, and check for understanding afterwards. And I think that's everything I have. Thank you so much for listening and being a part of this. And I just want to say thank you to some of the people who have given this presentation in the past and for all those who come afterwards.
Thank you so much, Dr. Way. I know it's a lot of information to get through. We just have a few questions in our chat. I'm wondering, I guess we can start with, what do you do in a situation where a patient or family member, or where you ask if they want to know the prognosis and they actually say no, but you think it's helpful for decision making?
Yeah, that's a really good question. I think I ran into this issue pretty recently. It depends on how urgent, like if there's urgent medication, if there's urgent medical decisions to be made, there are certain ways around it. You talk about, we want to respect that. Unfortunately, we're in a place where we have to make some urgent decisions. So we'll try to, let us know how you're doing, like kind of check in with them during the process of sharing the prognosis.
And what about when you're talking about prognosis, when you're talking about, or do you typically talk about time ranges with congestive heart failure when talking about prognosis, or more focused on what symptoms to expect?
That's a good question. You can do both, right? I think it's some people like to hear what to expect in terms of the course of the disease, like with symptoms, and other people want to hear about how much time, right? And a lot of times we actually try to to ask, because a lot of patients and families says, so how much time do I have left, right? And so it's always easy to rush into it, but make sure you take a step back and see, like, why do they want to know, like, what exactly are they hoping to hear? Because some people care more about the symptom burden, other people care more about the time that's left. So that's a good question.
And what about, how often would you say you're using objective tools for prognostication versus more like clinical judgment?
So it's a good question. It's a mix, right? Because sometimes we have some tools to guide us, but they don't, for example, for COPD, it's more for longer, like figuring out there's not a lot of tools that give us like a 6-month prognosis for COPD, but we use our best, and then we add in our clinical judgment. So almost like a 50-50 mix.
And then we have one more question about how do you approach other clinicians when you feel it may be helpful to share prognosis with patients and their families, if maybe there's some hesitancy there?
Yeah, no, that's a good question. And so in palliative medicine, and I think a lot of aspects of medicine, we always focus on collaboration, right? Like making sure all the clinicians, all the teams are on the same page. So it's one of those things where I in clinic and in the hospital, I reach out to different teams like through message or through email to say, hey, like I'm pretty worried about this. Like, do you think we should talk about this or that? And it's obviously easier when you know the specialist or the doctor on the other team. But even if you don't, I think it's you're kind of advocating for the patient in a bit when kind of asking for these discussions to be had. But yeah, it can be very, very difficult sometimes when clinicians are kind of in different places, right? Like, oh, from a specific organ standpoint, this is how the patient is doing. But overall, the patient is very sick or at risk of getting sicker. So it's nice to try to take a step back sometimes and look at the big picture of the person.
Well, thank you so much, Dr. Way. We really appreciate your time.
Thanks for having me. Thank you, everyone.